Hello everybody, welcome to week 3. Today we're going to, I think we just barely started congenital heart defects, so we'll get into the clinical and pathological appearance of them, and yeah, off we go. So where have we been? So we started the probe patent foramen ovale, and remember that occurs when the valve does not fibrose to the limbus within the first year of life. Remember, this is part of the fossa ovalis we talked about last time. Foramen ovale in the unborn, in the fetus, that thing swings way open. But once the fetus is born, the lungs work. And so that creates a very high pressure on the left side of the heart and a low pressure on the right side of the heart. Just kind of the opposite of the fetus, where the right atria is very high pressure, has very high pressure, and it's able to push blood. Oxygenated blood, right? We talked about how oxygenated blood comes from mom. So if about 20% of people to 25% of people have what's called a probe patent foramen ovale, and that means that the valve never fibrosed or welded shut. So most of the time it's no big deal, and you can go your whole life and not even know you have this. And that's because the high pressure over here will pressure close this valve against the limbus. And so when systole occurs, or when atrial systole occurs, this just is shut. So no big deal. You don't get a whole bunch of blood dumping in here. No big deal. However, if pulmonary hypertension develops, so, and these are the well, you tell me, what are these 4 things here? Those are the pulmonary arteries or veins? They're veins. They're bringing blood, oxygenated blood back to the heart. So that's what they are. But if these become really, really pressurized, it can raise the pressure in the right side of the heart above that of the left side of the heart, and then blood can backflow in. That's called a pathological right to left shunt, which is not a good thing. So that's kind of where we're going. So no big deal unless the patient develops pulmonary hypertension, usually from heart failure or COPD. And as I just said, when pulmonary hypertension arises, the right atria pressure increases because the right heart is having trouble pushing blood through the lungs and back into the left atrium because of stenosis of the pulmonary arterioles. And therefore, when the right heart pumps, it has to pump really hard and pressures get really high over here. So in this situation, you develop a pathological right to left shunting of blood. By the way, what I've just described is not Eisenmenger Syndrome. Okay, Eisenmenger Syndrome, we'll talk about that. That's kind of another buzzword for today, or if you don't know what that is, Eisenmenger Syndrome. And yeah, serious problems occur when deoxygenated blood mixes with beautiful oxygenated blood, and the patient will become hypoxic, and the tissue will starve of oxygen, and you can die from that. And clinically, you'll present with cyanosis, which is kind of a blue color, specifically a central cyanosis, blue over your entire body, your nail beds of your fingers and toes, your gums. So, not a good thing. Yes, again, this situation is not a cause of Eisenmenger syndrome, which is caused by volume overload. Too much blood blasting through the lungs causes Eisenmenger syndrome, as we'll see. Eisenmenger syndrome only occurs in congenital heart defects, atrial septal defect, ventricular septal defect, patent ductus arteriosus. A little side note here about cyanosis. So central cyanosis means there's a problem with deoxygenated blood that has mixed with oxygenated blood, usually from that pathological right to left shunt, which occurs from one of the congenital heart problems, ASD, VSD, PDA. Peripheral cyanosis is a different thing. That means that you have very slow blood going through an artery, probably because of an upstream beaver dam of some sort. And just like we've studied beaver dams in a river, if you beaver dam a river up, not a whole lot of blood flows through the river downstream. And that's the same thing. So if blood is moving really slow, the tissue has lots of time to steal all the oxygen out of it, and that will make you have a blue tint to whatever part of the extremity is experiencing that. So there's the beaver dam, a tumor pinching the brachial artery as an example. But you can have a generalized peripheral stenosis from a failing heart that's not pumping blood. Then you'll have this problem all over the body. All right. So that was we talked about the first congenital heart defect we talked about was the propatent foramen ovale, sometimes just called the foramen ovale. So this is new stuff now. Actually, some of this is new anyway. Eisenmenger Syndrome. But let's talk about atrial septal defects. So this is another cause of hypoxia, another congenital heart defect, and this is definitely a cause of Eisenmenger syndrome. Okay, so yep, it's one of the congenital heart diseases. It's a member of the cyanotic heart disease gang. So that means kind of the blue nail beds, blue toe beds, blue gums. If you're Caucasian, just blue skin in general. And yeah, congenital, of course, you're born with the problem. Cyanotic means that you're becoming hypoxic all over the body in this case. So again, the other members of the family were tetralogy of Fallot, the ventricular septal defect, patent ductus arteriosus. And there's several different subflavors of atrial septal defects we need to talk about. That's kind of the start of the show. We're not going to go through every single type of heart pathology today. I'm just kind of hitting the most important ones, the ones most likely to show up on boards. So prevalence is about 2% of births. So about 2 in 1,000 births, you'll be born with one of these atrial septal defects. 25% of these are associated with known genetic mutations. So if you are born with this, you have to be on the lookout for other congenital problems, horseshoe kidney, ectopic cordis, gastroschisis, things like that. Females are more common than males to develop this, 3-to-1 ratio. So of all the congenital heart diseases, this makes up about 13% of the pie, so to speak. It is the second most common type of congenital heart disease. The first most common is ventricular septal defect, although there is a caveat with that, as we'll see here in a bit. What is it? So here's that same view we've been looking at, a hole in the right atria, and we've been looking kind of from lateral to medial at the right atria, and there's the fossa ovalis there. So at ASD, atrial septal defect is just that. It's a defect in the interatrial septum. Typically, it shows up somewhere in the valve. The most common place is for it to show up right here, involving the limbus and the valve. That's called the Ostium secundum defect, which we'll definitely look at. But you can have them anywhere in the interatrial septum. Fun fact there, remember embryology, the valve of the fossa ovalis was derived from septum primum. The limbus derived from septum secundum. It's a separate sheet. Remember, the interatrial septum is 2 layers thick. There's 2 tissues except where the fossa ovale, the foramen ovale was, at the end of like week 39 or so, this valve has been formed, but it's only 1 layer thick. The limbus and above is 2 layers thick, septum primum, septum secundum. This is just septum primum, so it's a single layer thick. That's why you can shine a flashlight right through that piece of tissue. So unlike a propatent foramen ovale that's got a little flap there, this is a flat out hole in the interatrial septum. And therefore, once you're born and the pressures become very high in the left atria, you immediately have a shunting of blood from left to right. How come it goes this way like the picture? Because the pressures are higher in the left side of the heart normally. Okay, simple as that. The fetus, what about in fetal life? Does this cause any trouble? No, because blood is going from right to left, and it doesn't matter that there's a hole there, so there's no problem until the baby's born, until the pressures get high here. And now it just depends how big the hole is as to the clinical outlook for this patient. Also note that I did Photoshop this in. Notice the extra blood has a consequence here. It's clearly stretched out the left or the right ventricle as well as the right atria here, because you got, not quite double the load of blood, but maybe you got an extra 20% of blood coming in here, again depending how big that hole is. And it's not good for the heart, and it's definitely not good for the lungs, and this is where Eisenmenger syndrome is going to come from. What do you think of this? Give me a second to look at it. Does that look like a normal heart? Definitely a very little young patient here. No, we got a gigantic right atrium here. Right, and the right ventricle has pushed the left ventricle way over here. So this patient had a moderate size, like a medium size atrial septal defect, but it wasn't caught for a couple years, and it had already damaged the heart, which is a shame. Okay, so here's a little another demonstrating my amazing Photoshop skills. So what I tried to do is show you what happens when this glob of blood continually bombs the arteries and the veins of the lungs, because we know that the pathway is this, right? So blood is pumped out of the right ventricle, up the pulmonary trunk, out both pulmonary arteries or veins, pulmonary arteries. And after a long time, for a month or two, no big deal, but after we go 6 months, a year or so, that massive volume of blood starts to damage the small arteries and the arterioles, the pulmonary arteries and arterioles. And that's not good. So small pulmonary arteries and pulmonary arterioles, because of all that huge volume of blood irritating them, they start to become inflamed. And it tends to be a fibroblast heavy inflammation. And just like with any inflammation, after the endothelial cells get inflamed and that passes, they heal with fibrosis, especially if it's a fibroblast heavy inflammation. So fibroblasts come in, lay down scar tissue, and you get remodeling of these arteries, the small arteries and arterioles. And the tunica media and endothelium gets really, really thick, and it causes a beaver dam right here. And that's definitely not good, because the pressure, just like a real beaver dam, the water, in this case the blood going downstream, is going to be trickling. So one problem with all of these holes in the interatrial septum is that not a lot of blood gets back to the left atrium. So it gets cheated out of blood. Therefore, not a lot of blood gets into the left ventricle, and not a lot of blood gets ejected out the ascending aorta into the entire body. So you have a decreased stroke volume. And that ain't good in and of itself. And to make matters worse, we got this beaver dam upstream. It's like a beaver dam. The pulmonary arteries swell. The pulmonary trunk swells up in size because of the pressure. The right ventricle, right atria. So all of this pressure inside the lung is called pulmonary hypertension. What causes it? It's caused by high volumes of blood irritating the small vessels of the pulmonary artery to the point they remodel. They become inflamed and go through that whole process, fibrosed and remodeled, which narrows the lumen. And so now we have very high pressures in the right side of the heart, including the right atrium. So take a guess what's going to happen. Where's a picture? Where's the picture? I don't know where a picture is. These are brand new slides, by the way. I completely redid these slides just today. But you can imagine if there's a hole here and the pressure's higher in the right atria than left atria, blood's going to go the opposite direction. And that, once the blood goes in the opposite direction, that's called Eisenmenger Syndrome. Okay, just another look at pulmonary artery carrying deoxygenated blood. But this thing can get all swollen and scarred up, and the lumen can be very narrow. And that acts as a beaver dam. And yeah, beaver dam, as I said, blocks the flow of blood. And yeah, everything I said. Pulmonary tension occurs. The right heart pressure quickly rises above the left heart pressure. And here's the picture I was looking for. And now, because of that beaver dam in the small arteries, the small pulmonary arteries, and the pulmonary arterioles, look what we got. We got a reverse of blood flow. So the blood's no longer going from left to right, it's going from right to left. And that's called Eisenmenger Syndrome. Once the pressure rises above the left heart and the blood flow reverses, Eisenmenger Syndrome. We're not going to talk about ventricular septal defects because I have so much ground to cover, but a ventricular septal defect is the same story. The pressure only pushes blood through the defect down here. But that's also called Eisenmenger Syndrome when you get a pathological left to right shunt, and that's immediately going to cause hypoxia. Body does not like that. Results in total body hypoxia and its indications, which is cyanosis, all over the body, right? Because the heart is the main pump. So it's not going to be in just the right arm or the right hand or the right foot. It'll be all over the body. So what's the ultimate sequelae of that? Well, it'll destroy your heart and lungs to the point you need a transplant or you're going to die. Typically, if it's a small one, it'll take decades before it destroys your heart and lungs. A medium one will take... Did I get this messed up? No, that's right. A large one is going to take months. It'll be very fast. It's much more dangerous. A medium one can take years, and a small one can take decades. I didn't get that messed up. All right. Great. How about some of the other signs of Eisenmenger syndrome where you have cyanosis or maybe you don't have a cyanosis yet, but you have kind of a low-level ischemia going on because of that pathological right to left shunt. So generalized cyanosis, so blue-tinted skin and gums. If you do a hematocrit, what's going to show there? Because you have a decreased ejection fraction or decreased stroke volume or don't have as much blood coming out of the heart, plus that blood is not 98% saturated with oxygen, maybe it's 85% or 75%, some cells in the kidney tubules are going to sense that, or in the kidneys are going to sense that, and they release something called erythropoietin in response to this hypoxia. That is a hormone. It's going to get into the blood. Remember we talked about that, about how athletes used to use that the substance to cheat. Because it's a hormone, it gets into the blood, it goes into the bone marrow, and it stimulates Polycythemia. It stimulates the creation of more red blood cells to help carry that lower oxygen. If there's a drop in oxygen, then we need more helpers to carry the diminished oxygen. And so the blood gets really thick, which is the increased hematocrit, and the increase in red blood cells alone, which you can see in a simple lab test, that's called polycythemia. Great. Another one, clubbing of the fingernails. So seen in 40-50% of patients with congenital heart defects where Eisenmenger syndrome has started. And we don't completely understand the pathophysiology, so I won't get into it. But yeah, they look like clubs. If you look at your fingernails from the side, you should have a very faint V when you go from distal to proximal and you're looking at a lateral fingernail. Here, you don't have that. You just have these big old concavities. Or I guess if you look on the outside, they're convexities. They're curved. So they look like clubs kind of. So that's indication of heart, typically, and it can be other things, but typically indicates heart problems. Although I've had students have these and be terrified, and they can be completely normal, and people get them idiopathically. We don't know why they get them, but they can be completely normal in a small percentage of people. But if you see them, especially in someone older, you always look at the heart. Something's going on. The hypoxia also drives the heart crazy. Greatly increases the chance for arrhythmias, especially atrial arrhythmias, especially atrial fibrillation. The stretched out heart from the extra blood in the right atria, that stretching irritates the cardiomyocytes, and it greatly increases the chance that they will take over pacemaking duties and can set up a little racetrack of current, the local reentry circuit, which an atrial fib can run those atria at about 550 beats per minute. Remember we talked about that. Thank goodness for the what? Thank goodness for the what saves the day. Because you can't live if your ventricles are going that fast. Good, your AV node, that decremental conduction property saves the day. You're going to get right heart failure if this isn't treated, because your right heart is not going to allow the left heart not to get filled up with blood, so it's going to try to pump really, really strongly. And eventually it'll wear itself out. It's not designed like the left heart. It can wear out fairly quickly. Yep, remember polycythemia means there are too many red blood cells. Great. And here's just some of the different types. We'll look at a couple more of these, but there's the osteosegundum. Let's actually talk about that here in a second. So atrial defect. So there's an atrial septal defect and a ventricular septal defect, and they're both defects of the interatrial and interventricular septum, respectively. The most common congenital heart defect of adults is said to be the atrial septal defect. And that's because atrial septal defects are not under super high pressure, so you don't have a ton of increased volume of blood going into the lungs. Unlike a ventricular septal defect, where huge volumes of blood can go into the lungs. So if there's just a small amount of extra blood going into the lungs, Eisenmenger syndrome can take decades to show up. It's not always true, but in general, the most common congenital defect, heart defect in the adult, is the atrial septal defect. Everything I said. Uh-oh, did I miss a slide? Yeah, everything I said here. Why don't the symptoms show up until adulthood? Everything I said. Atria is under low pressure, and therefore it takes a long time for that overload, that volume overload, to cause Eisenmenger syndrome. I'm looking for... Yeah, geez. I'll have to bring those slides back. I did get rid of those slides because the next question is the most common congenital heart defect in children is what? That's a ventricular septal defect. And that's because the ventricle's under much higher pressure and therefore much higher volumes of blood get in and cause Eisenmenger syndrome much more quickly compared to atrial septal defects in general. And there can be exceptions to that rule, but that's the story with that. Does Eisenmenger syndrome cause cor pulmonale? What is cor pulmonale? And the answer is no. Cor pulmonale occurs when the right heart overworks to the point of failure. So cor pulmonale is right heart failure. However, it has to be secondary to some lung pathology. Certainly, the number one cause of right heart failure is what? It's actually left heart failure. The left heart fails and you back up blood into the lungs, through the lungs, all the way back into the right heart, and the right heart tries in vain to correct that problem, and it blows out. It has to be secondary to lung pathology. The classic example is COPD, chronic obstructive pulmonary disease, which is usually a combination of emphysema, and chronic bronchitis. Here are the causes of cor pulmonale. So COPD is by far the most common. Pulmonary fibrosis, interstitial lung disease, crackles. I always think of crackles, that oscillatory sound. Pulmonary fibrosis is the number one cause of those. And watch out for this, chronic pulmonary thromboemboli. So people with, and what's the most common cause of thrombophilia? Right there. That'd be a good question, wouldn't it? That's factor V Leiden. Factor VIII is another one. There's a bunch of them. But these people need to be on blood thinners, because even if they don't have a big old pulmonary embolism and have to go to the hospital and get it fixed, they can be having micro, very small embolism being shed from the veins of the lower extremities. And their lungs can be getting subclinically bombed and irritated to the point where the arterioles, pulmonary arterioles, start to become inflamed. And they start to shut down, and the pressures slowly start to creep up, so you slowly develop pulmonary hypertension. Obstructive sleep apnea, high altitude chronic hypoxia, all causes of cor pulmonale. Here's someone who died. They actually developed a paradoxical embolism after a long airplane ride. They did have the paper said slight pulmonary hypertension, but it was enough they threw a clot from the airplane ride out of the deep veins of lower extremities. They went up, instead of going to the lungs, it shot through the PFO, just kind of bad luck, and they got a paradoxical embolism, which is an embolism that's not in the venous system, which it usually is. It snuck into the arterial system, and that can be deadly, cause stroke, heart attack. I think we talked about that last time. Let's look at the specific ASDs now. By far the most common of all the subclasses of atrial septal defects is the Ostium secundum defect, also called the secundum ASD, septum secundum defect, but yeah, by far the most common type of ASD, probably 80 to 90, or Rubens, according to Rubens, which is a board book, right? Rubens pathology, about 85% of the time, it's a Ostium secundum defect. More common in females, way more common. 70% of these are in females. And this one is a little tricky to understand, because why would they call it a secundum defect? So that's because most commonly it doesn't involve only the valve. It involves the limbus. And the limbus is part of that ostium secundum. The valve is ostium primum. So that's embryologic tissue thing. So it takes both tissues. So that's where ostium secundum comes in. Okay, typically not dangerous in the short term. The holes usually aren't too big, and the atria aren't under super high pressure. Usually takes decades to show up. What else do I want to say? I think that's about it there. So unlike a pro-patent foramen ovale, this one always shunts blood, right? We know this, kind of went through this already. It always shunts blood. And depending on the size, typically they show up in adulthood. But they will eventually, if they're not caught, they will damage the lungs enough where Eisenmenger syndrome and pulmonary hypertension will show up. And once that happens, you get that pathological right to left shunt. And this hasn't, so if I put that on the test and said, has Eisenmenger syndrome started yet in this patient? With an obvious blank, I could say. An obvious atrial septal defect, and no, because the blood is still flowing left to right. So that Eisenmenger syndrome has not occurred yet. Okay, sinus venosa defect. This is another type of atrial septal defect. Very confusing to get the story down on this, but I do have the story down on this. And both of these sinus venosa, there's a superior and inferior sinus venosa defect. And this is the way it works. It's still considered by most authors a intraatrial septal defect. The superior sinus venosus defect occurs in the very upper part of the intraatrial septum, pretty much through the limbus. So it's superior. The inferior sinus venosus defect is down low. There's one that's even lower, but it's down low. So yeah, very confusing to get this down. Yeah, everything I said, both of these involves an abnormal communication between the left and right ventricle. Both have the ability to spark Eisenmenger syndrome because, yeah, we got shunting of blood. It'd be unusual to have both of these at the same time. To save time, I just drew them on here. Yeah. I think everything I said. So specifically, let's talk about just the superior sinus venosa defect. So again, it's a defect in the intraatrial septum, but it's very superior to the intraatrial septum. It's about 5% of all atrial septal defects. Problem embryologically speaking with the development of the superior part of the sinus venosus, which goes on to form the intraatrial septum. Some authors don't recognize it as an intraatrial septum defect because it involved formation or malformation of the sinus venosus. But most, like Robbins does, so we're going to do that. We're going to call it an ASD member as well. But there's a weird part about this. So not 100%, about 85% of the time, you have another weird communication, and it's typically between the superior. Well, you tell me, who is this coming back? Those are veins, superior pulmonary vein, and either the superior vena cava or the right atria itself. In this cartoon, we see a new vessel has grown and kind of is shunting blood from this beautifully oxygenated blood. It's dumping it right into the superior vena cava. And so we're losing that. We're increasing the blood volume here, and it's happening over here as well. So 85% of the time, there's a double leak, basically. And so that can cause Eisenmenger syndrome. Could take time. Again, it depends on how big the holes are. So yeah, sets up oxygenated arterial blood to spill over into the deoxygenated blood. Body tolerates this pretty well until Eisenmenger's syndrome starts. Yep, Eisenmenger syndrome can definitely start. Usually these are small, so it shows up in middle age or even later. Great, we've already explained that. So much rarer. Inferior sinus venosus defect, very rare, 1% of congenital heart defects. And it occurs down low, like this little picture. This is where the inferior portion of the sinus venosus failed to develop correctly, and it leads to a hole between the right and left atria. That shunts blood. There's nothing else associated with this. Nothing coming off the right or off the inferior vena cava, nothing off the superior vena cava, so you can erase those two. It's just this one right here. Great. So same thing, you get an initial shunting of blood left to right, but after decades, Eisenmenger syndrome will show up. Okay, now this one's even lower down, way down in the intraatrial septum. Let's call it an Ostium primum defect. So it's a hole in the inferiormost part of the intraatrial septum, so far down that it's by one of the cusps of the tricuspid valve. So it's more inferior than an inferior ostium sagittum defect. Makes up about 2% of all congenital heart defects. This one is not caused by the sinus venosus not forming right. This is a problem with the endocardial cushions which form the heart. I'm not sure if we got to the embryology of heart formation. I do have videos of that you might want to watch. Maybe eventually I'll put a new video up here on that, because it's kind of complicated. It's almost a whole lecture in itself. But yeah, and so you get this really low down hole between the right and left atria, and it's in the intraatrial septum, and it shunts blood left to right at first. After decades, it wrecks the heart, and wrecks the lungs, and you get pulmonary hypertension, right-sided heart hypertension, and then pathological right to left shunt, and Eisenmenger syndrome has begun. Same story with this. The interesting one about this one, about 50% of Down's children have this defect. Great. So what is the treatment for any real ASD? Well, you can put in a graft if it's large enough. If it's a small one, you can just leave it alone, and oftentimes it closes. But if it's large enough to possibly cause Eisenmenger syndrome, it needs to be closed. And here's you can see the sutures. They put a dark crown graft in here and sewed it in, and everything's good. That problem is over, except is it over? These little sutures here don't go away, and that could be a breeding ground for bacteria. You go to the dentist, have a root canal, and get a dose of bacteria going through your blood. They can cling onto this thing, and they can start growing and growing, and bacteria are like rabbits, right? They multiply like crazy. And you can get a big bug ball here that can break loose, and who knows what side it's on. If it's on the arterial side, it can kill you. It can act just like an embolism. So that's why when you go to the dentist, if you're having major work done, you always go on antibiotics, just in case you get that dose, especially if you've had some heart problems, heart surgery like this. So it increases the risk for bacterial endocarditis. That bug ball embolism is called a septic embolism. All right, one more and we're out of here. Patent ductus arteriosus, PDA. So some anatomy, remember that. There is the ductus arteriosus, the remnants of it. Remember, after you're born, that thing scars shut. Now it's called ligamentum arteriosum. A little anatomy of the aortic arch. I think we've done this before. This is the ascending aorta. B is the aortic arch. C is the one you usually don't know. That's called the isthmus of the aorta. And it happens right at the beginning of the isthmus is where this ductus venosus and ductus arteriosus and ligamentum arteriosus attach right in this area as well. So I could ask you, at anatomy, I could ask you any of this, so make sure you know. A pulmonary, what's that called? Number 2. Pulmonary trunk. Did I list it? I didn't list it. Yeah, I did list it. Brachiocephalic trunk. Remember that splits into a number 3, right subclavian artery, right common carotid artery. There's the left common carotid artery. There's the left subclavian artery. So make sure you know all these pieces. Brand new test coming. Remember the ductus arteriosus? We talked about that last week when we talked about the fetal circulation. So it's a communication. It's a little tube that connects the end of the pulmonary trunk to the isthmus of the thoracic aorta, or the isthmus of the aorta, that little piece right after the left subclavian vein. And normally, in fetal times, the lungs don't work, so there's beaver dams. There's like a roadblock down where the lungs are. So pressures are high, and some of this fairly well oxygenated blood can be recaptured by pushing it into the aorta here. But once you're born, the pressures wake up. Pressure drops actually here because the lungs are working. And so there's no need to keep that. And usually before birth, that thing is already scarred up. So it typically goes away. But sometimes it doesn't go away. Yep, everything I said. Before development, most of the pulmonary blood passes through ductus arteriosus, everything we said. But doesn't always go away. So in some people, that duct remains open. And yeah, that's called a patent ductus arteriosus, a PDA. And it's fairly rare in full-term babies, like 0.1%. But in premature babies, 10% of them have this ductus arteriosus that never scarred up. And this is more dangerous than the other defects we've talked about. We'll see here in a second. But one of the dangers is that it's associated with ventricular septal defect as well. Okay, so now if this duct is open in the baby, because this has low pressure here, this has high pressure, blood is flowing not this way, but blood is flowing from the aorta. Beautiful oxygenated blood is dumping right into the pulmonary arteries and going right on into the lungs. And this is very high pressure, right? So a lot of blood can go in here, and you can injure the lungs real quickly, and Eisenmenger syndrome can start fairly quickly in this condition. By the way, the number one, the most deadly congenital heart defect is called a transposition of the great vessels. I'm not going to get to that this quarter, but check out the recording next quarter. I'm going to do these recordings and just keep posting them. So help students prepare for boards. Yeah, so large quantities of blood will dump from that high-pressured aorta, everything I said. And Eisenmenger syndrome can start very quickly. Children can become hypoxic from Eisenmenger syndrome sometimes hours or days after birth. So this is not a good one to have. And there's the cartoon of it. So high pressure now, the baby's born. The low pressure that used to be in these vessels, right here, they're gone. And so the higher pressure of the aorta is much higher than that of the pulmonary trunk and pulmonary arteries, so blood goes from area of high pressure to low pressure. So now we got way too much blood going into the lungs, and they get wrecked. Yeah, I said this. They become hypoxic very quickly. 65% of newborns will die within 6 months if this is not fixed. So to make things worse, as we said, about 40% of the time, these kids have a more dangerous ventricular septal defect to begin with, or to make things worse. Okay, that's enough. I'm trying to keep these, not like overload you with information. So email me if you have any questions, and I will see you next week. Well, I won't see. I'll see you guys in class, and I think I have about half of you in endocrinology. So ask me questions if you have any questions about this. All right, see you later.